Doxol, that would be 240. If you gave even 6 cycles of FAC, that would be 300. I was just trying to figure out where 480 comes from, because that's like double what we normally give. Now,
that's a double of the usual dose.
Are you sure it was adriamycin? It wasn't epirubicin, right? It was clearly doxorubicin.
It was doxorubicin, yes. Because I checked the history, I mean the folder of the history, and they have a special sheet. Then when they write all the doses by date, and
Okay.
at the end they summon that doses, and they have 480. I mean, it's too much. I try to talk sometimes with the oncologists about the maybe possible interventions or the doses, but they decide.
So I would just be curious from an educational perspective, if you wouldn't mind, would you be able to get that chemotherapy regimen? I'd just like to see what it is, because I don't quite understand where those doses came from. So and even the cyclo, you said it's usually 600 milligrams per meter squared, with the 60 of you can do of Adria with 4 cycles. So that's, you said 12 grams. Is that what you said?
Yes.
That's a lot.
Yes.
Okay, so my own education as a breast cancer oncologist, I'd just like to curious as to know as to what they're using, or what regimen that was.
I don't know exactly. I tried to interview with this oncologist specialist in this case particularly, because I follow this patient because they obviously have some cardiovascular implication and symptoms, but I cannot talk with this guy.
But I think from an educational perspective, particularly since this had a bad outcome, that
Yes.
In terms of when I go and I give talks, if I can give sort of, examples of what happens when this type of therapy is given, I can, it's only, I think, through education that we're going to be able to change that. So if I
Yes.
could, even borrow your case, if I knew what the regimen was given, I think it's a good example of what can happen, particularly when we use perhaps higher doses of doxorubicin than we really need to.
Yes, exactly. So, what I do is I talked with the chief of oncologists, which and he told me the same. I mean, this is out proportional. I'm going to talk with the specialist, and I'm going to supervise all the doses from now on. I don't know what happened here, but exactly the why this doctor made this choice, or why I don't know. I just see it, the patient 3 and 6 months later, and of course, this is the results about don't follow exactly your regimen, and that for the people who believe until this day that the cardiotoxicity is a phenomenon that you don't see, or maybe it's invented. This is quite a good example of the damage of the myocardium with this medication.
So, can you guys hear me?
Yep. Yes.
Yeah. Hey, it's Joe. I got cut off, but in that last discussion, my guess is that this person is 2 meters body surface area, and 480 was the total dose, and not the per meter squared. And it probably somebody made a wrong notation, because there's no regimen where people get 480 milligrams of doxorubicin for breast cancer.
2 meters square in the country of Mexico, it's very rare.
Oh, really?
Yes. No, and it's 240 times 2 is 480. So I'll bet you that was the total dose and not the per meter square dose. That's all. Sorry.
Okay. Maybe it's okay.
Can we just clarify? I mean, later on, obviously not sure, but maybe we could clarify that.
Yes, that's what it's put on paper in the history. It's 480 per meter square. So I'm going to recheck this data, but really for people in Mexico, 2 meters square, it's a very not normal. Also in the Providence that I live, the people, it's maybe the height, it's 1.55, 1.60 meters, you know, and
That would be a very, very big person, right? Because I can tell you, so we do see that in North America. It's not that uncommon, but you know, 2 meters, it would be a big person. I agree.
yes,
So curious. Okay.
for a woman. I don't understand.
Mhm.
I think you can, yeah, you can proceed.
Okay.
Yeah.
Thank you. So we're going to go to the second case. This second work of art. It's a 41 years old female, no hypertension, no diabetes, breast cancer, same, ductal carcinoma, stage 2A, HER2 positive. We are going to see the echo. Left ventricle at the beginning is normal. This is the spiral pressure. As you can see, it's normal function of the left ventricle, but what we see is that a three-dimensional analysis of the left atrium. We have 29 milliliters per meter square, which is normal in the new guidelines. Remember, the past guidelines say that more than 28 you have dilated, but they're correct at more than 34 in the guidelines of 2015. So we have a normal left atrium. These both cases that I present, it's part of a work that I was follow for more than 140 patients with breast cancer, that we analyze the strain of the left ventricle, strain of the right ventricle, and left atrium volume index. So I take these two. So what happened at 3 months? At 3 months, the woman come with palpitations to the new echo, have 350 grams per meter squared doxorubicin, 8 grams of cyclophosphamide, and after that, 2 milligrams per kilogram every day of trastuzumab, which also I believe this is huge.
It is.
It's huge. I mean, left ventricular ejection fraction doesn't have any change. Okay, I can hear you. Okay, someone's
Yeah.
going to have comment.
No, I think there was some background noise there.
Okay, so we have normal left ventricular ejection fraction, global longitudinal strain have a drop less than 8, exactly 5% only, circumferential drop of minus 2%, 1 to 2% in PROMEDY at 3 months. But when we analyze left atrium volume index, we have 36 milliliters per meter square. And we do a Holter monitor, which is 24 hours monitor, and we see atrial fibrillation. As we can see, this is the Holter monitor of the patient, and we identify atrial fibrillation. So, what is the evidence in the internet right now? This is 2016 Nature Research, Dr. Jean, that say that before and after the therapy of the oncology therapy, we have change on the percentage of passive emptiness and active emptiness on the left atrium. We have some abstracts of the 2014 and 2015 ACC meetings that talk about the longitudinal strain on the left atrium, and also we have this publication about Dr. Leopoldo Pérez de Isla, which is in Madrid, España, and they say also that they have changes on the left atrium longitudinal strain by 3D motion tracking, and also changes on the left atrium volumes after chemotherapy or the therapy of cancer, and with no other cause, because this patient doesn't have blood hypertension and they have no pathology on the mitral valve. So Uh, any comment of this case?
Yeah, I mean, those findings are interesting, but in your patient, you know, he's an AFib. I don't think you can make any of those observations. I think the AFib is, we don't understand how significant strain changes exist when a patient's in AFib.
In AFib, well, about the measuring strain in AFib, or what?
Yeah, I think,
Okay.
right, I think.
No, no, I don't measure strain. The people who from Spain, they measure strain, and remember, this is AFib paroxysmal AFib. So by the time that we make in the study, the patient are in sinus rhythm. So I don't measure strain on the left atrium. In my study, what we follow are volumes, which are more strange parameter than strain, because left atrium strain are studied in ischemic heart disease and in other pathologies, but not in cardiotoxicity. So that's why I only measure in the left atrium volume, which is a measure that they are already standard on the guidelines and on all these methods. So that's why I measure volumes. These two works, they measure strain. I believe these people, I read these papers, and the people who are measuring strain, it's not in AFib at the moment. So that's why again, if the patient have AFib, you cannot measure or the strain is going to be plus positive 3 or positive 4. I mean, because it's in fibrillation.
Okay.
Okay. More comments?
Yeah, I think that uh, the difficulty with certainly diastolic filling parameters to assess diastology, and then, you know, in my opinion, strain measurements, and then also in this case, you know, left atrial measurements in a patient that's in AFib or paroxysmally in AFib, you have a lot of difficulty there, because all of your measurements are going to be dramatically influenced by the differing RR intervals.
Yes. You have to be very cautious when you're taking the measures, because you need to see the diastolic parameters on the left ventricle. A lot of people, when see this case, that they say that it's maybe the diastolic dysfunction making that the enlargement of the left atrium because of the chemotherapy. But that when we analyze this 130 patients that we have, we see that the diastolic function are changed, but are not so dramatically changed. We have E and E prime wave relationship less than 14, which is now on these guidelines of the diastolic function of this year. It's a very good parameter to check. And also we don't have an elevation of the systolic pressure or systolic pulmonary pressure, or we don't have an E wave less than 4 or 5. So in this particular case of these women, we don't have so many parameters with okay.
Okay.
Okay. We don't have so many parameters that tell us that the diastolic function is very bad, that can make the enlargement of the atrium. So that's why I'm showing you these cases, because these cases are not as we see all the days on the lab, on the office. I mean, this is cases, this is more rare cases with a very highly dose of chemotherapy, right ventricle dysfunction, and left atrial enlargement. We are usually see patient with half drop on the longitudinal extent of the left ventricle, changes on the ejection fraction, and that's more common. But these cases are particularly different, so that's why I'm showing.
Super. Yeah. No, that's very interesting.
So, anybody has any question?
No.
Nobody? I'm seeing the panel, but I don't see any question.
No. Yeah. I think.
Yeah.
I think that. Yeah. Go ahead.
Yeah, it's Veronica. How are you?
Hey, Veronica. How are you?
Congratulations for the conference. Unfortunately, I can't see anything here. All the time I was trying to see the images. Unfortunately, I couldn't see anything. I'm sorry. And just wonder how was the diastolic function of that patient before the treatment?
Before the treatment, the patient is completely normal. I mean, she don't have any high blood hypertension, no diabetes, have 41 years old. I mean, the parameters, all the parameters that establish the 2016 guidelines are normal. At 3 months, we see a small change. I mean, the E wave is less than the A wave, but the E prime wave doesn't less than 6, so that's good. We don't have elevated pulmonary pressure, systolic pulmonary pressure. The E prime ratio by tisular Doppler, it was 12. So all the parameters that you need to see are practically normal. Just the change about the E wave less than A wave on the mitral annulus, and the mitral and the inflow of the left ventricle. Sorry for my English.
Oh, right. Yeah, are we ready? Yeah, okay, cool.
Okay.
Yeah. Then, now I think that the challenge with all of these measurements is that they really are very dependent on, volume status, but also, rhythm. And so I don't know, I'm pretty skeptical on these mechanical measurements whenever you have, a very small change looks like it's significant, but the actual change is very small. So for example,
the changes in the volume.
Yeah. So I mean, even if you measure the left atrium, and one day you put it close to the wall but not quite to the wall, and then the next day you put it on the other side of the wall, you've just changed it by half a centimeter, and that makes the volume a lot different. So I think that those measurements are pretty rough in general. Eric, I don't know if you have a comment on that.
Let's see, Ronald Crone had a question. He's had his hand raised for a while. Ron, can you talk?
Hi, Eric. Yeah. This is kind of intriguing. I mean, a long time ago we did a paper on atrial fibrillation and never could correlate it to anything. But it's interesting to start looking at the left atrial valve. I agree with Dan. I mean, these measurements are, they're written and they seem to be precise, but when you actually work in a lab, you see how how they're not. But it does raise a question that it's worth pursuing. We have an astrophysicist / cardiologist who's developed a load-independent measure of diastolic function, which hopefully will get around this problem of volume and measuring diastolic function. So we're looking into that. But I think this is an interesting observation, and it may be followed up. It'd be nice to be able to predict atrial fibrillation before it happens, and perhaps rather than giving prophylaxis to everybody, which nobody does because it's it's got problems. So I think it's an interesting thought.
Andres has a question. Hey. Andres?
Hi, how are you?
Good.
Yes, I have a question for all. In the practice, do you use some score to determine the probability of cardiotoxicity of this patient? because we have a rate factor. We all we know that we can describe in the patient to have cardiotoxicity, but we don't have in Argentine a score determine the probability of cardiotoxicity of the Dr. Ruicina or Persipinas. Do you use in your practice some score?
I think that we don't, in Nashville, I wouldn't say that we've achieved being able to do strain on a reliable basis on patients that are receiving anthracyclines or other toxins. So I don't really know what the measurements are per se on just your average patient. So pretty much to define, evidence of cardiotoxicity, then we base it really on EF changes.
I would like to bring that up and address that for a minute. We decided 2012 that we were going to do strain here, and so we went to the administration and they wanted to know what kind of volume you had, and we really weren't sure what kind of volume there was going to be, and so basically we thought it was pretty important to check the different vendors, and we sent someone to Houston, to MD Anderson, to doctor that's there, who is actually one of my students, and he was very, very cordial, and our tech stayed there, and we had several vendors bring their equipment over. So we had Biosound, we had Philips, we had everybody bring their equipment because we're going to compare it on the same patients while my tech was there. And my tech was with Jose Banches, and he did a great job, and there was a fellow there at the same time, and she was very engaged, and we decided that we were going to try to join the SUCCAR study with Tom Merrick, and Tom in Tasmania was very, very nice to give us some online instruction as well as send us a bunch of cases, and then we did the cases, and then we sent them back, and then we were graded on the cases, and the cases have been published now for actually self-testing and grading, which is excellent. And so since that time, we do strain on every patient and after a while, it doesn't slow down throughput at all, and you start getting some competence in strain. Recently, Dr. Marwick published an article about left ventricular hypertrophy and patients with hypertension and patients with strain, and that strain was predictive of future cardiac events if it was dropping. And so that was very good. And so we've been using strain every day on a frequent basis, and it suddenly starts to click in where it becomes very helpful because your tech becomes standardized, your strain becomes standardized. We have the General Electric package. We have the top of the line shipped to us from Norway, and we were trained with Dr. Marwick, and so we've really gotten good at it. And actually, I had a question today for Dr. Marwick that we sent to him about correlation of CT MPI and myocardial echo strain and coronary cath FFR. And so after a while, we really get sophisticated with it. So I just wanted to make that point that if you do it every day and you do it all the time, and it's a well-trained tech, and well-trained means actually been schooled by Dr. Marwick and Jose Banches, we feel like we've got a real grip on it. But it was very shaky, and it took us a while, and I really poo-pooed strain for a long time. And we're just actually getting in the groove where it's very meaningful to us.
Okay. Can I just say more comment?
Sure.
The thing as a clinical cardiologist, when I see this AFib, I need to search. I mean, why this woman is presenting atrial fibrillation. That's why I gave turn my eyes in these volumes, because these volumes, 36, is 2 milliliters per meter square more than the risk to present AFib. There's a lot of publication and some meta-analysis in the Journal of the American College that say that more than 34 milliliters per meter square are a very high risk for the patient to present atrial fibrillation or maybe stroke. So that's why as you can see, I search, I identify the strain, the left ventricular ejection fraction. I don't put it on the screen, but the diastolic function, and also this parameter. So that's why I remark this parameter, because now, as Dr. Dan says, the software, you need to be very careful, because if you don't do it, or you don't see that the software is follow very well all the walls, you can have very bad measures or mistake in the measures. But this patient has 29, now she has 36. Maybe you cannot have need to see it, because the volumes can change because of the machine, as Dr. Dan says. But the thing is here that we have some clinical points. I mean, the patient present AFib, and the only risk factor for AFib in this patient is this. Doesn't have any risk factor. As I say you, these two cases that I present are cases that we don't have it every day. I mean, not at my lab or at my office. Maybe you see it more, but I don't see it. So that's why I present these two cases of these 140 women that I'm following. These are two cases that particularly have some interest, because the things, I mean, the first one was the right ventricle dysfunction associated with a so huge medication, and these have some longer, have bigger left atrium volume, but with clinical translate, which is AFib. And in this 140 patient, I have 3 patients who present AFib. All have more than 34 milliliters per meter square. They have palpitation, and they manifestate they present on the 24-hour monitor AFib. So that is not very usually. So that's why I present these 2 cases for discussion.
Yeah, no, I think, AFib is an important finding, and definitely indicates that, essentially that's a stress response. So the patient's not really handling the chemo okay.
Exactly.
Something has changed, and so
exactly.
Yeah, I think the AFib is an important event, no doubt.
Question about that. Okay.
Someone has a question?
Yeah, I guess there are other sort of risk factors that are more elusive, such as sleep apnea, that sometimes is readily discovered, or familial history that's not known by the patient, but they have an up gene or a down gene for atrial fib, and so there's some other less mysterious things.
Yes, exactly. Well, and at the history of patient, they don't have obesity. She don't obese. So, and I believe the mechanism of the sleep apnea, it's one of them. It's have overweight, but she don't have it. Exactly if she had or not. I really don't know. I don't see it at the history. I don't ask. I don't send this patient to study, but I'm going to send them to a special test to diagnose sleep apnea, and they have history of atrial fibrillation, but their parents, not the parents, their families, and aunts or an uncles who have blood hypertension, they have atrial fibrillation, but if you have history of families which have atrial fibrillation and they have blood hypertension, you cannot relate to some genes of some hereditary condition. You know, it mean they develop atrophy AFib because of the blood pressure, not for maybe some family issues. I don't know. I know there are so many strange things that I can study for this patient, which have AFib, which are three. But the thing in the internet and in the literature, the only risk factor that I can see or that I can found, it's more than 34 milliliters per square meter of the left atrium, which is a very studied parameter. And as I say, there are several meta-analyses which demonstrate this relation with this AFib and stroke and this manifestation where you have more than 34 milliliters per meter square. So, if I may, I can conclude, just not quit more of your precious time. Cardiac dysfunction secondary to cancer therapy is real and affects the myocardium. Other cavities more than left ventricle are also affected by these therapies, because as you can see, cardiac dysfunction secondary to cancer therapies affects the myocardium and the hypothesis is, as you know, right ventricle has myocardium and left atrium has myocardium. Different, more sensitive because it's smaller and thinner, and we know by other studies that the left atrium can develop fibrosis for other things. So the hypothesis is that myocardium can be damaged as the same that the left ventricle, but the right ventricle and the left atrium. And it's necessary to remark other cavities besides the left ventricle to avoid clinical complication, which is at the end of the way the thing that we are making so many studies, we're making so many good and nice imaging. It's the end of the way is to help this patient to have a better life and avoid these all complications. And thank you.
Fantastic. Thank you so much.
Thank you so much, Rafael. We ask for any other comments that anybody might have that may or may not be related to our discussion. Andreas, Brian, we have Edward Spangenthal, Joe Carver, Lauren. We will actually want to take a moment to introduce our attorney and new board member, who is Josh Wadowski. He came to our meeting to find out more about what we do. He's self-muted right now, but he might be able to say hello. Josh, can you say hello to our group? I think you've got your mic open now, Josh.
I have the comment. Can you hear me?
Yes.
Oh, hello.
Hi,
Yes.
Sebastian.
Sebastian, how are you?
Yes, here Sebastian. I had some problems, technical problems, but the presentation was excellent. The second case was very interesting for me because I have observed some patients with iatrogenic atrial fibrillation. I can confirm that trastuzumab or anthracyclines may induce atrial fibrillation, especially in patients with history of paroxysmal atrial fibrillation. And for example, I remember the patients with lymphoma during treatment with anthracyclines. These patients may experience next episode of atrial fibrillation, and this episode may predict acute heart failure. What do you think about this relationship?
Yeah, I mean, I think that's probably true.
Yes. Well, sorry, do you hear me?
Yes.
Yes, Andres, thought. Well, the last week I have a patient with lymphoma she received doxorubicin, 50 milligram square, and she had acute toxicity with right and left ventricle function and atrial fibrillation and clinic and we have to assist with a balloon and connect to RAM. So we have very problem with these people. This patient will make also levosimendan, and then now is better. This patient. So do you have any experience about acute toxicity?
I think that, again, atrial fibrillation, especially, at least in my general view in these patients, is really a stress response. So, if a person's getting treated with multiple drugs, including anthracycline, and then they develop atrial fibrillation, it's definitely that there's probably some evidence of actual cardiotoxicity, but also it's probably just reflective of the overall stress response that patients undergoing aggressive treatment.
Now I think that time to think how to treat the patients with atrial fibrillation in history.
Yes.
Yeah, I think that, they'd have to be considered very high risk if they have a history of it.
Yes. The thing that I want to show in this case is that we need to beware of more cavities, not only left ventricle. As the doctors say, trastuzumab have some relation, but we don't have so many material online about these medications have a specific target or damage the left atrium. It can be like Dr. Dan says, that maybe it's stress for all the medication and the other thing, but also they
Hello?
Well,
Did we lose somebody?
Sounds like it.
Yes, I'm here. Andres, do you hear me?
Yes,
Yeah,
I
we
hear
do.
you.
Hello? Hello?
Yep, we hear you now.
Oh, okay.
So I wanted to make sure that we acknowledge everyone who is here. And atrial fibrillation, for me, has also been a stressor and acute event, although we've studied the left atrium with late gadolinium enhancement and segmentation to look for fibrosis as part of the DCAF study, and found that they were classified by Utah standards of Utah 1 through 4, depending upon how much fibrosis there was, and that told us that there were changes that were significant in the left atrium that were chronic in all patients that we were seeing, and the ones with Utah 1 had the least fibrosis, and Utah 4 the greatest fibrosis.
right.
And so we had some correlation with the ability to be able to ablate based on the amount of fibrosis in the left atrium.
Okay. Yes. Maybe with maybe with another studies we can establish that. And I don't have any experience with levosimendan and acute dysfunction, but if you are starting to have cases, I please start to do your correlation and make some papers so we can understand and know more about this condition, because I don't know if other people, but acute dysfunction for chemotherapy, I don't have any experience in that.
That was my first case of acute toxicity with doxorubicin. So we make the levosimendan infusion, and then we assist the patient with the balloon because she was in multi-organic failure. So that was a critical case.
You need to write that case.
So I don't have any experience previous.
Yeah, well, at least in the U.S., you can't really use levosimendan, so.
Let's see, we want to welcome Mark Westwood from Brompton, who's here today for the first time. Hey, Mark, how are you?
Yeah, good. Can you all hear me?
We can hear you quite well.
Yes, yes.
Hi.
Great. Okay. Yeah, I'm sorry I joined a little bit late, but yeah, I've been listening. Very, very interesting and informative. And I noticed we've managed to digress the discussion onto some late gadolinium enhancement imaging, so making me feel a little bit more at home, I guess, in terms of my preferred imaging modality. I'm interested that these correlations are found. I know when we've tried to do late gadolinium enhancement to look at scarring in the atrium, we've really struggled. It's really technically quite challenging. So you can find some people you can do it really easily, and others it's extremely difficult. So, but fascinating nonetheless. But yeah, from what I saw, great cases.
Thank you. Thank you so much for your comment. Yes, of course, we can do a late enhancement on the MRI. The thing is, MRI is maybe not so available, because when I go to MRI lab and I say that I want to see late enhancement on the left atrium, maybe some of the imaging person, they just give me a look like, what are you saying? So that's why I'm not sending so much, but it's interesting. I'm going to send these 3 patients. We have 8/5. I'm going to send them. I promise to send them to MRI, and I promise to send you to your emails, maybe in 2 or 3 weeks more, the images about if they have late enhancement or not.
Good. That'd be great.
Yeah, I mean, I guess unless you've got a very large MR department, just to look for late gadolinium enhancement in the atrium is usually about 20 minutes just to run that sequence. So, or maybe 15 if you're lucky, if it all kind of goes completely to plan. But yeah, it would be fascinating to know what that showed.
I promise to do.
Great.
All right, well, I really appreciate everybody joining in, and we will have another webinar next month on the second Thursday. That will be, what day is that? The 9th, November 9th. We'll hopefully get to talk about how Donald Trump did not win the election, and
please need to be.
I'm so nervous. Gotta go. Thank you.
We need to be politically neutral in our conversations, Dan.
Yes, we do. So sorry, that slipped out.
Capability of muting you. I can mute you at any point, and so I want you to be aware of that.
If Dr. Han say that doesn't happen, I just cannot assist to the webinar because I'm going to be constructing the wall.
Okay. Fantastic.
There was actually a report on CNN last night that groping was a result of strain.
Oh my God.
Yeah. Or another form of
Start
strain.
muting everybody, Eric.
Please, we don't want any comments about lying Hillary as well.
Yeah. Start muting everybody.
Okay, let's go. Dan, we need you to stay on.
All right.
Susan, we need you to stay on. We also have Janine Podolsky, who's joined us in terms of staffing. And so we're going to have a little meeting for a second. So thank you so much for coming. We had a great conference today.
Yes, I will just want to ask for the doctor who says about the MRI. Can you please, doctor, send an email to this email that you have shown, you're seeing at your screen, so I can return to you the images maybe 1 or 2 weeks later?
Certainly. We can do
Yeah,
that.
we'll make sure you get connected there.
Okay.
Yep.
Thank you.
Super. Thank you so much.
Thank you. Thanks to you. It was very
Daniel?
nice.
Okay.
Thank you. Thank you, Rafael.
Bye-bye.
Bye-bye.
Daniel?
Bye-bye.
Daniel, do you hear?
Yes, I'm still here.
Yes, well, Andres. No, I appreciate the approved of the Icos. I want to say you. I send a mail to Eric. The Icos at the site of Argentine of your society. I appreciate that the executive committee approved that. I will work very hard in this country to make the cardio-oncology a very important weapon quality here.
Yeah, no,
Yes.
thank you so much. We
Well,
appreciate all your
I
efforts.
want to say thank you all.
Super. Thank you so much.
Thank you so
Bye-bye.
much, everybody. Appreciate it. And let's see, we will change here to change the presenter. And so hang on for a minute, and we'll make Susan the presenter. And so, Susan, you are now the presenter. Susan Dent. Okay. And then
Yes.
people that are leaving now.
Anthony things.
So,
I don't have
Hello,
anything to present.
how are you? Yes. Hi, how are you? Susan, do you hear me?
Yes,
Hello.
we can.
Yes. Well, I'm Andres Daniele. I'm from Argentina, Buenos Aires. I work in the institute, in the RAFO Institute. I was in charge of the cardiology department of this institute. Do you know how is the RAFO Institute in Argentina? Do you know?
No.
No. Well, here is the public, the first public hospital, oncology hospital. It's the is reference in Argentina. We attend the most people in this country of oncology pathology. I want to develop the cardio-oncology here and in the hospital in Argentina. That is a specialty in cardiology that is not now developed in my country. So I contact Daniel and Eric, and they give me the possibility to from the Icos the site in Argentina of the Icos. So I very I appreciate that opportunity. So I want to work hard with other colleagues, oncologists, hematologists, very different specialty to make here in Latin America center of this specialty. Yes.
thank
Sorry,
you so
but
much,
my English
Andreas.
is not very good.
Thank you, Andreas. We look forward to the Argentina chapter. Thank you.
Yes. Well, thank you very much to you for giving me the opportunity to make the chapter here.
Perfect. We really appreciate it. It really, it's really important that you have established all of these great efforts. So.
Well, in the next week, I will contact Sean Fay to make all the web and these other things.
Okay, fantastic.
Thank you.
Well, but I leave you in peace.
All right, we appreciate you getting on. No problem, and we will, be keeping you involved in we also do a webinar on the 4th Thursday too. So, and that one's more of a planning one.
Okay,
So,
thank you very much.
so we'll include you in
Well,
that.
bye.
Thank you.
Bye. Bye. Bye.
All right, thanks a lot.
Bye-bye.
See you next month.
Fantastic.
Okay, that's good.
I think we've done it. Okay.
Okay. Well, that's a good segue probably into our discussion, isn't it?
Yeah.
I'm sure it is.
So I don't have any slides to show anyone. I just thought that we could talk about moving forward with Nadine and what her role might be. So in looking forward to GCOS next year in London, my understanding was that you know, Nadine could, one of the possibilities would be for her to be a resource in trying to help and plan that meeting with the understanding that there would be also some resources in London on the ground that would be necessary anyways to look at venues and so on. And so how that would look in terms of commitment, we can discuss. The second part would be, you know, is there a role for Nadine in Icos, and if so, what would that role be in terms of helping to bring on new chapters such as Brazil, Argentina, and so on as they try and develop their cardio-oncology programs in their own country? And thirdly, could there be, you know, a little bit still that she could do for CCON? So I guess essentially what I'm saying is that...
And then I would add the fourth thing would be if she could help to coordinate the ongoing registry efforts. I don't think I'm going to be able to submit that grant for the deadline in October, so I'm going to defer it until February. But, you know, part of that would be to, you know, really get our documents all together, and actually I would like to go ahead and start the registry, submit it at Vanderbilt, and then I know Marilia in Brazil wants to go ahead and start it too there, and so that we could use it as a test case to see if it's working. And by the time we get around to submitting for the grant in February, then we would already have 3 or 4 months worth of experience of actually doing the registry. So I think that would be extremely valuable, and if Nadine could help to coordinate those efforts, that would be really superb.
I agree. So then the question becomes, you know, we can, so basically it's sort of it's a piecemeal job. I mean, it would be, you know, 3 different groups, and that's fine. So right now she's reimbursed through an account here through our research institute, and I put money into that account, and I said, you know, perhaps it would be better moving forward if she just went out on her own as a consultant and then billed hours to the appropriate organization. So, I mean, I certainly could do that, but then the issue becomes if she is that an issue, Eric, for you guys in terms of, you know, if she says, okay, I've done this much work for Icos, can she send you as a consultant or whatever we call her, can she send you an invoice, and can that, would it work that way? I think that's the cleanest way to do it, rather than, you know, right now it's not going to work. The way she's being reimbursed is through sort of our own research institute, and I think that would be far too complicated.
Yeah, so I think that if we outlined a specific task that we would want her to do, and if Dan could outline those in like a letter of intent of exactly how much time would be needed per month and our expectation of the amount of time, and then if we can contain that in terms of, you know, 10 hours a month or 20 hours a month or whatever our allocation is going to be at so much per hour, and then she would document that she's accomplished those goals, and then we would send her a check.
So that would work out okay?
Yeah.
I think that's fair enough.
Dan, that sound good to you?
I mean, I'm good with however is an appropriate way of doing it. I think that, you know, there is, right now, I mean, even in the very near future, and probably in the next week, I know that there's a planning meeting for 2017, and so
Yep.
Alex has been the one sort of leading that effort, but we've already acknowledged at every level with the British Cardiovascular Society and everybody else that Nadine would be, you know, an essential part of that whole piece. So that table's already set. So there's the future meeting piece that she is an essential component. Then there's, you know, whatever component of CCON you want her to do. So, you know, you have to decide. You have to decide that. But then from an Icos perspective, the two biggest things that I see are, you know, the registry, if we could actually get that done. And then I don't know exactly how much time is required for all those documents, but it's a lot more than I can do. And
I know.
and Nadine is tremendous. So, you know, that part, you know, I don't know exactly how much time it takes, but I know that if I have somebody smart like her helping to get them looking right, then you know, that's only going to be a good thing. And then, you know, with that, extending, you know, that whole effort into trying to find resources outside of the NCI is what we really need to put some effort into in the next few months. So I texted Eric yesterday about, is there any way we can contact some representative of IBM and start talking to them about Watson and see if we can get a cardio-oncology module in Watson, or, you know, something like this. And
well, you know what? I have a contact for that, because Ottawa here is supposed to be part of the IBM Watson thing. So I know someone who's working on that here in our center.
Okay, well, there you go. So if you know, if Nadine could help broker some of those gaps, that would be huge, and I think that would be really tremendous work for, you know, for Icos in general, for sure.
That's
So
good.
I guess the question is, Eric is raising funds to support that.
Yeah. So what we
support Nadine.
Yeah. So what we need from you, Dan, would be some kind of time allotment, and from you, basically, Susan, would be a per hour Canadian salary per hour that she would bill for. It wouldn't be a salary; she'd be a consultant, and basically per hour she'd be responsible for her own benefits and her own taxes and so forth. And basically, if Dan could write up just a letter of intent in terms of, one, specifically what you need on the registry and the documents and so forth, and how much time you think would be reasonable for her to spend per month working on that, that would be great. And then for the next part, which would be future grant development, if you want to allocate some amount of time to that per month, that will be fine. And then third,
and then, the other piece would be the navigating the different international groups that, and, you know, or helping John or however to improve the website and, you know, make everybody have a page and all that.
Yeah, we're working on that now, so I think we'll have that covered with John, and with each participant from each country. They're going to submit their stuff, so I don't think we're going to need that right now. I think we'll have that pretty well taken care of. And so that.
So Dan, if you think you could turn that around, like within the next 3 to 4 weeks?
Yeah.
The letter of intent and on responsibilities. So I can tell you that, you know, everything you've mentioned to date is great. That's probably going to be more than 5 hours per week, though. Everything you've mentioned, Dan. But anyways, we can see what you think, and then Nadine also will probably be able to, maybe I'll ask her to comment too. She is cleaning up from the GCOS meeting, so don't forget she has to coordinate the whole thing about public, all the abstracts being published in the journal, all the feedback, collating all the responses, you know, doing all that. So there's still a bit of cleanup from the GCOS meeting. getting all the, you know, I have all the videos. We're going to upload them to the website, et cetera, et cetera. So there's a bit of a cleanup period over the next few weeks from the meeting.
Sure.
But if you can do that, and I will ask Alex to do the same thing from the you know, the GCOS next year side, in terms of what his expectations would be in terms of hours per week. You know, that would work out great.
Okay, sounds good.
Sure.
Okay, and then I will do the same thing from my perspective. And I'm hoping, you know, between the conference next year, what we need to do with the registry and Icos, and a bit from CCON, that surely that we can sort of piece together, you know, sort of a full-time position. I mean, I think that's reasonable. There's lots to do.
Yeah,
Yep.
I think there's a full-time position.
And then Eric, you can keep me updated in terms of if I can help in any way in trying to raise funds.
Yeah, yeah, that's good.
I know that you're working on one person, but they're waiting till after the election, right?
Right, after the election. So we'll see what happens for that. And so we'll engage her as soon as the election's over, the next day.
So was that promising? Did that sort of look promising?
Yeah, it did.
Okay. Okay. No, I mean, that would be great. That would be great. Okay.
Right.
So
Super.
any other
Thank you,
feedback
guys.
from the meeting, Dan? Did you hear any other feedback?
Oh, it's been nothing but 100% positive. So yeah, it's been great.
Okay. Good, guys. Okay, so you have that to do, and I'll do it now, and I'll speak to Alex about doing one as well. The letter of intent idea and the